Thank you, Kiran, for the kind introduction and organizing this webinar and inviting me to talk. So I'm going to discuss the HELIX trial results and the implications. I hope most of the delegates participating in this webinar have already read the HELIX paper. If not, please do read it fully, not just abstract, read the paper fully. But this is a brief summary. So it is an open label phase 3 randomized control trial with masked outcome assessments. 408 infants from South Asian neonatal units with moderate and severe encephalopathy were enrolled and randomized. And then the intervention group was whole body cooling. Control group was usual intensive care with avoidance of hypothermia. And the primary outcome was the composite of death or moderate or severe disability at 18 months. So, and the primary outcome was seen in 50% of the cooled infants and 47% of the control infants with a p-value of 0.55. And we had a primary outcome in 97%. So there is a follow-up rate. And the conclusion of the trial was that the whole body cooling does not reduce death or disability after moderate or severe encephalopathy in LMICs. So that's the trial in a nutshell. So what I'm going to discuss today is not the endpoint, but how we got there, the making of the HELIX trial. Because before we get to the final point of one of the greatest moments in our history, there is a lot of net practice that we need to do, a lot of practice matches, and then we get to the final match and the final win. So that's what we did with the HELIX trial. So this is a decade of work by a lot of people from India, Bangladesh, and Sri Lanka. A lot of very passionate and committed people. One of them is joined as a panel here, Ismat Jahan. So before the trial, there was almost 5 years of feasibility studies and pilot studies, and then we did the main trial. So what you actually see in the Lancet, the 10 pages, is actually 10 years of work. So what I mean by pilot studies is that pilot studies, when we do, they are not powered for the primary outcome. That's how you differentiate a pilot study and a main trial. And you can either use a biomarker outcome or a short-term outcome. But essentially, they will not have adequate power for the primary outcome. And you don't necessarily need to have an IDMC in a pilot study. But of course, when you do a main trial, you do need to have an IDMC. If not, you're in big trouble. And you don't need the same governance requirements, and smaller teams can do pilot studies. But it's absolutely essential to do those before you jump onto the main trial. So like I said, that went on for many, many years before we embarked on the HELIX trial. So a lot of net practices, a lot of practice matches, and then the final game. And of course, we cannot say we've won a lot of practice matches, just give us the World Cup. It doesn't work like that. You do need to win the final game. And that's what we had eventually. So I'm just going to discuss some of the decisions we made in the HELIX trial and how we got there, essentially the making of the trial. So how did we select the population that we recruited into the HELIX trial? So we all know, I'm just going to use India as an example here. We all know the population is very diverse. Some of the richest people in the world live in India. And of course, some of the poorest people live there too. And whom do you choose? This is a famous inverse care law, initially published in Lancet by a very enterprising GP called, general practitioner called Julian Tudor-Hart, who died last year. So he coined this for the first time, the inverse care law, which we all know now, that the availability of medical care is inversely proportionate to the needs of the population. So in India, we have top-end private hospitals there in blue, which has got the same facilities and service the population, which are pretty similar to high-income countries. That's at the top end. But they do have lower delivery rates and very high cesarean rates. So many of hospitals, like we did explore, including Manipal Hospital, but it had a cesarean rate of almost 80%. So I'm not sure what the burden of encephalopathy in those settings are. But of course, if cooling is effective in those settings, it doesn't mean it can be extrapolated to all other settings. And if you go to the other bottom end, where if you go to the villages and tribal population who don't have access to proper healthcare, which unfortunately does form a big chunk of India, as in sub-Saharan Africa, cooling clearly does not work. It's dangerous to do cooling there. And one of my colleagues, Nikki Robertson, has shown that if you do cooling in those settings, you're going to increase mortality. And then there's a big chunk of tertiary and secondary care with a huge burden of encephalopathy in India. But we decided to go towards the top end, just because we want to be make sure cooling was safe and effective in those settings before going on to lesser resourced secondary and tertiary intensive care units in India. So the population, the hospitals we selected were public sector hospitals, academic centers, with moderately high burden of HI, usually around 5 to 10 per 1,000 live births. And all these hospitals had facilities for ventilation, cardiovascular support, and a two or three tied medical care. So there was a specialist neonatal consultant, and then in the UK, we call that as senior house officer or a registrar. So those were junior doctors equivalent there. And neonatal nurses with a ratio mostly between 1:2 to 4. So that is sites, and this is one of the trial sites in Bangalore, in Indira Gandhi Hospital. Although we had very good relations with one of the nearby hospitals called Vanivilas, who had a huge burden of encephalopathy, which was also a kind of tertiary intensive care. We did not feel cooling would be appropriate there. So that's why we chose a nearby hospital called Indira Gandhi. This is the neonatal intensive care unit there. As you can see, the cooling is being given by a Datandon machine there. And these are the trial sites of HELIX in India, in South India primarily. Sayan Hospital in Mumbai, Indira Gandhi Hospital in Bangalore, 2 hospitals in Madras, Kelani University in Sri Lanka, Trivandrum Medical College, and BSMMU from Dhaka. So these were the HELIX trial sites. Now, the second issue is how did we select these babies? How did we make sure these babies did have moderate or severe encephalopathy and not mild encephalopathy? So if the key to it is to do a very good standardized neurological examination. So we had certified examiners at all sites. So this is a structured examination that Siddha Shankar developed for the NICHD trials and has been validated extensively in a number of high-profile publications subsequently. So this is exactly what we use. There is a system for training and certification of all the investigators and the people who were recruiting, which both Siddha and I did. So all of them are certified and validated. These exams are never available online, and also there are a number of documents that's freely available if anybody wants to learn this. But it is absolutely essential to do a structured examination. Otherwise, you will overcall mild HI as moderate for sure, unless you use amplitude integrated EEG alongside. I mean, in the UK, nobody is very good at doing this. Even in the UK, most people don't do a proper neuro exam and are cooling babies with mild encephalopathy. But if I ask my colleagues, they will invariably say, oh no, we don't cool mild HI, it's all moderate. But unless you do structured examination, you will end up cooling mild HI for sure. So this is what we did for HELIX trial. Now, why is the standardization so vital? Because we really want to pick up the high-risk group, the high-risk infants with moderate or severe HI. But why is that so important? So this is a graph. Just look at this graph carefully. I'll show this again. So this is plotting the power of the study against the control event rates. By control event rates, what we mean is the adverse events in the control group. So that's control event rates. The sample size of any trial depends on the control event rates. So any intervention in newborns will have around a third relative risk reduction. You can pretend it has got 100% relative risk reduction and has smaller sample size, but in reality, it doesn't work like that. So if you assume a 30% relative risk reduction, this is a graph you will get. So imagine we are doing a trial of 400 infants, and your event rate is 50%, you have then around over 80% power. Now, if you recruit infants with milder encephalopathy or milder brain injury, your event rate will come down, say come down to 30%. All of a sudden, your power of the trial is down to less than 50%. That's a disaster. Then you cannot conclude anything. And of course, if the event rate is much lower, you're in big trouble and something is seriously wrong. So that is why the standardization of encephalopathy is so vital. But we did not use quad pH as an inclusion criteria, and I'll tell you why. I mean, of course, quad pH is a useful indicator because metabolic acidosis may indicate a recent hypoxic event. But more importantly, lack of acidosis may suggest lack of a significant event as well. But the issue in LMIC is that outborn infants rarely have quad pH done. And although many trials do report as quad pH as an inclusion criteria in LMIC, the denominator data is rarely reported. So I don't know, how many babies do actually get a quad pH done, especially among outborn babies. And that limits the generalizability in LMICs. But instead, we use pH at admission, metabolic acidosis at admission, which was available in more than 90% in the HELIX trial. And we made sure we excluded alternative causes of encephalopathy, metabolic genetic causes, and so on. Now, how did we fine-tune our intervention, and what kind of pilot studies did we do? So this was the first randomized control trial, pilot randomized control trial we did. Like I said, it was not powered for the clinical outcomes. So we used something called phase change material, which is a bit like ice, but instead of melting at 0 degrees, it melts at a set temperature, 27 or 28, whatever you want to set it. So this was this is the first human demonstration of a phase change material for therapeutic hypothermia. So this mattress was developed by a company called Matter. It's pretty cheap, just 100 pounds, which will be 10,000 rupees, Indian rupees, it seems. And this is the Neonatal unit in Calicut Medical College that you can see. The photo, so we appointed around 6 research nurses to do the study, at least to provide a good one-to-one care when they were getting cooling. So we managed to do therapeutic hypothermia with phase change material, but my concern was both induction and rewarming cannot be controlled because there is no induction or rewarming phase in those. And the cooling efficacy is dependent on the ambient temperature. So when the temperature was pretty high, which can happen in tropical countries, it doesn't work. But we found that we used Thompson's criteria as an inclusion then in this trial rather than NICHT criteria. But we found that was just not good. We are recruiting infants with mild encephalopathy. We also found that there was a lot of white matter injury in this population, a lot of microcephaly. So there was something which some population differences were apparent in the small study. And then we went on to develop, we got a grant from the Gates Foundation, and we went on to develop this servo control cooling device, which is essentially like an old Nokia phone. If you people still remember, this is the Nokia version of the iPhone that we now use, but it does the job. There's only one set temperature of 33.5 degrees. You switch it on, it just maintains that. And then you can switch a button off after 72 hours, it'll rewarm at 0.5 degrees per hour. So this is a device we developed, was just costing 500 pounds, around 50,000 rupees, in collaboration with industry partner called Inspiration Healthcare. So our only condition was that until we have the results from the HELIX trial, they should not market it, because I didn't want to market a device just going to where we are uncertain about the safety and efficacy, and the company was pretty happy with that. So this is one of the meetings we had in Calicut at the time. So one of the representatives, Nikki from Inspiration Healthcare, or there, and you can see Professor Vishnu Bhatt, who has been an absolute pioneer in this field and a true inspiration figure for me. And this is Sruthi, one of the DM fellows doing a study on cooling at Shipmer at that time. So we did the initial pilot studies with this machine. So this is the baby we used, we trialed in Calicut as well. But eventually, both these hospitals could not participate. In Calicut Medical College, you thought it was more like an upper secondary level care than a proper tertiary full-blown. And in JIPMA, there was a lot of nursing shortages, and getting hourly data was difficult. So eventually, both these trials units could not participate, although there were a lot of credit does go to these two centers, both to Professor Bishnu, and also to Professor Kumuda from, she's not in this photo, from Madras Medical College, who was also present in that meeting. And then we did some pilot studies using this machine in Madras Medical College. So this is the data from 58, about 120 babies, 58 cool babies, and 112 infants to usual care, which is kind of normothermia, although we didn't measure the temperatures of those infants in the study. And the mortality rate was half in the cooled infants, which was quite reassuring. Of course, you cannot say anything about safety and efficacy of cooling from a non-randomized trial, but this was reassuring. And then we went on to do the full main helix trial. And the main helix trial, we used this machine called Therapeutic Neo. And the reason why we used that was because there was no downloading function of all the data in the Therapeutic Helix, and we wanted to examine the rectal temperature every minute, which we could do with this machine. So the key question, of course, you people would ask is, did we actually achieve the target temperature within 6 hours? Which we did. This machine was highly effective. Within 10 minutes, you can really rapidly cool down infants with this machine. And all except 3 infants did have rectal temperature of target temperature less than 34 at 6 hours. And in the 3 who did not have reached that temperature by 7 hours in the next hour. Now, we use normothermia as a control group, although this was not, we were wiser by that time by the experience of the original cooling trials that Professor Sita Shankaran and the Toby trial that Imperial College did earlier. Because all the original cooling trials had a lot of hypothermia in the control arm, which we now know will worsen the adverse outcome. So the adverse effects of hypothermia is several times higher than the beneficial effects of cooling. So Sita was absolutely adamant we should have strict guidelines for avoiding hypothermia, which I'm quite glad we did. And we also measured the temperature for 90 hours, not just 72 hours, to make sure you don't get a fever later on. And then we continued the measurement for the first 1 week, 8 hourly later on. And we avoided hypothermia by setting lower temperatures in the radiant warmers and a lot of other things. But despite all this, 10 infants did have at least 1 episode of hypothermia, because it's just so difficult to prevent in high resource settings. Or the high resource settings in low-income countries, hypothermia is just so common. It's uncommon in sub-Saharan Africa, where you don't have radiant warmers, but in the UK, hypothermia was very common prior to the cooling trials. But all the ones who had hypothermia had adverse outcomes. So the ones who had a temperature of more than 39, all of them died. The ones who had temperature between 38 to 39, they were survived but had disability. So be very, very careful of avoiding hypothermia in these infants. Now, was the consent rate in Helix trial truly informed? It's never, this is one of the biggest challenges, not just in LMICs, but in the UK, because parents just have a few hours to make a decision when their child is just so sick. And it's very easy to say yes without understanding what you're signing up to. So we made sure we trained all the people as much as we can. A lot of mock training went on before they were allowed to consent. And then we video recorded all the consenting. And then we analyzed all these videos in a quantitative way. So we looked at how empathetically the clinician was talking to parents. We looked at whether they provided all information about the trial. And then we looked at whether they had the autonomy to withdraw from the trial or not to participate without giving a reason, and without and understanding that that would not affect the quality of the care that their infant would receive. So it all scored highly on these quantitative measurements, but always, as always, the devil is in the detail. So we then went back and did qualitative interviews with the parents and also with the clinicians. So this is one of my fellows, Sudeepan. So she did his qualitative interviews. And then when we asked these parents, they said, yes, we did participate. We participated because the doctor told us to. They had complete trust in doctors, and that's why they did, which is a good thing. This is the same thing they would do in the UK as well. And they felt that the treatment was beneficial, and it should be given to more people. So this was before we unmasked the data from the HELIX trial. They did not know the results, but they thought the cooling was pretty beneficial. Same from clinicians. So clinicians really was finding it difficult to explain the concept of randomization. And this is an issue, not just in LMICs, but in the UK. It's very difficult to explain randomization to patients. They would just want the intervention arm, not the control arm. And clinicians were not happy because a lot of hospitals were already cooling in LMICs. So they had this thing we call as moral distress. Now, how did we ensure randomization quality and the quality assurance of the trial? So we had a web-based remote randomization with a strict audit trail and inclusion criteria logs. So what I mean is that if the infant is more than 6 hours, 6 hours is in 1 minute, then it will not allow you to randomize. And we cross-check this by checking the time of birth to ensure this integrity. That's absolutely important, because by people trying to help, people might push a baby son of hours of age into the trial, just trying to help, but that's not good. So this process will not allow that. And of course, we examined the temperature data by downloading it. We had extensive training and very dedicated and committed research nurses and a core team of fellows at each of those sites. That is absolutely crucial. And whenever I appoint a research nurse, I tell them it's absolutely fine to have missing data. I don't like it. They will get they'll get told off when there's missing data. But if you force, that's your last day with our research group, you'll be dismissed instantly. So, and they knew that. They were really, absolutely committed people. I really hats off to their hard work, and we couldn't have done with the dedication of commitment of the team. And of course, there were automated algorithms to look at the data accuracy and so on. And all the data was checked at multiple levels, but the local levels, local PAs, trial managers, and we went through every single variable in every single case. And we, like I said, we examined the videos of all consent and stored them. Whenever there's almost all cases we used to discuss in real time. There's a WhatsApp group, we just used to discuss any case. If there is any complex case, both Sudha Shankaran and I used to discuss management. Assessment of Baileys again was cross-checked. Each form's photos of Baileys were taken. Not because a lot of things are we do a standard in any clinical trial in the UK and routinely, but we went an extra mile. Not that we didn't trust the local teams. Of course, we had, I had absolutely committed teams. But in case people finds, we just need to be absolutely sure the data quality is spot on when we do these kind of trials. Now, why did we choose a primary outcome of death and disability at 18 months? All the high-country cooling trials have done that. And that's for a reason. This is a well-accepted and standard thing that the primary outcome for any neuroprotective intervention should be 18 months, a composite of death and disability, because they're competing outcomes. I would have liked if we could do an assessment at 1 month. It would have made my life much easier because all my work is on neonatal encephalopathy, but we can't. We cannot assess the development prior to the age of 18 months. That's the earliest we can do. So absolutely mandatory primary outcome should be the composite of death and disability, because if you have more death, the disability can be artificially lower and vice versa, because they're competing outcomes. And the issue in using this outcome in LMIC is that the follow-up is extremely challenging. Often there's a migrant population, they change homes, not just from one place to another, but into different states altogether. And I'm not aware of any trial that has got a high rate of clinical trial that has been done in LMICs with a high follow-up and a rigorous neurodevelopmental assessment. So this was a huge, very tall order when we started off, but really admiring, hats off to all the people who managed to do this. So people traveled, investigators traveled long distances, taking flights at times to travel to different states to do the Bailey examinations. And it was especially challenging during COVID. So we had to do all those PPE stuff, mask, and use open air assessments, and so on. So all the examinations were standardized, and they did masked assessments of the outcome. Now, we had a very experienced IDMC team in HELIX trial. And why is that? I'll tell you why it's that important in a minute. So this team had two of the top people in the field, Prof Sudhin, who was the PI of a number of cooling trials, including the delayed cooling trial by NICHD, and Naren, one of the most respected people and an authority in the field, and Professor Shabar Jaffer, Professor of Epidemiology and Head of Leopold School of Tropical Medicine, absolute leader in epidemiology and statistics. So, and then we also had two neonatologists, one from the UK and one from India, Niranjan Thomas, which many of you would know, very passionate and committed people. And there was a clear statistical analysis plan, and the protocol was published prior hand. And in clinical trials, it's absolutely mandatory to stick with the statistical analysis plan. If you say, for example, if one of your outcome is neonatal mortality, it's not same as mortality at discharge, and you cannot use it interchangeably. And you need to specify mortality at 20 days is not same as mortality at 30 days. So whatever you say in your statistical analysis plan prior to the trial, you should just do. So interim analysis was done 5 times during the trial, and the IDMC was watching like a hawk. And once the trial results were published and there was harm in one group, both Sita and I went back to the IDMC and said, look, why did you not stop the trial? Because one of the previous trials that Sita Shankaran did, the optimizing cooling trial, was stopped for futility. And they were absolutely clear. They were really watching, like I said, like a hawk at the data. And when we went back and looked at the mortality, the data results we would have after each 100 recruits, and this is what we found. The first 100 recruits, absolutely no difference in p-value, just one p-value, same event rates in both. First 100, again, no difference. First 300, again, no significant difference. And there's only when we got to the full 408, or more than 400, the difference came. So the IDMC did make an absolutely correct call in continuing the trial, but of course not allowing it to go any further than originally planned. So really hats off to the hard work of the IDMC as well. So then the final thing is whether the HELIX trial reporting was comprehensive, which we think is, so you should read that paper. There's extensive data, both in the main paper and also in the supplementary appendix. So we could have easily published 10 different papers from the data, but we decided to just publish one paper with all the information in. So it'll take you a good afternoon to read the paper carefully. And before we published, unmasked the data, when we had a meeting of all investigators in the team, and we interviewed all the teams separately and recorded this, because it's pretty common in randomized controlled trials. Once we unmask and analyze the data, some PIs may not like what they find, and they might, so we just made sure everything was recorded prior to unmasking. And I was really surprised at the peer reviewers. They was just so supportive, and they're just so impressed with the quality of the HELIX trial data, and same with the Lancet editors. But do read all the comments about the HELIX trial, which is published in the Lancet and the reply, and again the supplementary appendix. So that's again was quite pleasing. But what was so different about the HELIX trial and the Heineken country trial? So here we are looking at the three main cooling trials. The NICHT, the first whole body cooling trial, NICHT trial published in NEGM now almost 15 years back, led by Sida Shankaran, CoolCap trial, and the Toby trial, led by Imperial College. If you look at the death, the outcomes of death, disability, follow-up rate, and sepsis rate was pretty much the same in all the studies. Birth weight was half a kilo lesser in HELIX trial because the population was different. But the striking differences are in red. Hypothermia, like I said, was very low in HELIX trial compared to other trials. But look at the incidence of seizures. Many more infants had seizures at the time of randomization in HELIX trial compared to the high-income country cooling trials. And much lower proportion had acute sentinel events like cord collapse, abruption, and so on compared to the high-income country cooling trials. But is the data similar to other cooling trials? I think so. I would, if you look at the birth weight, it's pretty similar. If you look at the perinatal sentinel events, it's pretty similar in LMIC cooling trials. Most of them had reported event rates, perinatal sentinel events in 5 to 10%. Most of them had a similar nest into thin trial from CMC Vellore, which is one of the reasonably well-resourced private hospitals in South India. They had a nurse to infant ratio 1:3 to 4. Many trials had even worse or not even reported those kind of supportive care. Again, hypothermia in control arms. I'm surprised none of the Indian trials have reported that, but I'm pretty surprised. It's extremely unlikely that they did not have hypothermia, but it's not been reported in those studies. Early onset seizures, again, very similar, almost 80%, more than 80% in many of the trials. And I'm really interested to know about Prof Sudhin Thayyil's experience in these early onset seizures in these infants. And of course, HELIX is the only one which uses servo-controlled cooling device. All other devices, all other trials used low-cost manual devices. So, but if you look at the, so in HELIX trial, we are lucky that our event rate was pretty similar. The control event rate was pretty similar to what we predicted. So we had more than 80% power for our primary outcome. But one of the other phase 3 trials, a last trial by Zhou et al. From China, multi-center trial, that trial had a power of around 50%. But other studies, excellent studies, a lot of them led by Prof Sudhin Thayyil, had powers of 30% or lower. The thin trial, again, a very good study from CMC Vellore had 5% power. So these are very useful studies, but we should not make definitive conclusions about clinical efficacy using this. And if you combine all these results, again, it's pretty much similar. So the only 2 trials are reported death and disability in a masked way from LMICs, as far as we could see. But hypothermia does not improve the composite outcome of death and disability when you look at the pool data. So this again, for us published. If you look into the appendix in the Lancet paper, you can see that. If you look at the mortality, again, cooling does not reduce mortality at hospital discharge in LMIC when you look at the pool data. That's all fine. But when I talk to a lot of my friends, they'll say, no, Sudhin, this is all fine. But in my experience, cooling does work. How do you explain that? So I'm going to explain by using this model. So imagine this is one of the mouse experiments based on the original Paolo's thinking. So this is a mouse, and every time this mouse touches the red button, it gets an electric shock. Every time it touches the blue button, it gets some pellets to eat. So of course, the mouse will keep on touching the green button or blue button more and more. And if you look at what people do, so we start with cooling babies with mild, moderate, or severe encephalopathy, which is continuum. No baby is going to say, I got mild, I got moderate, or I got severe. It's very difficult unless you do a very standardized examination, as we discussed. And then what do you find? The ones with severe HI are dying more often. Then you stop cooling severe HI, you try and focus more on the mild and moderate one. Then you see the moderate end ones are also dying. Then your drift starts again. You're starting cooling just with babies born in poor condition, but with no HIE. And this circle goes on. And this is what that has happened in the UK, not just in LMIC, in the UK as well. So following introduction of cooling therapy in the UK, I think we have eradicated mild HIE. People will say, oh, we don't see, we don't cool mild HIE. That just suddenly disappeared. So where has this gone? Now, if you look at this excellent data from the Indian Neonatal Collaborative, 17 units, this is the kind of studies we need. 350 infants, 211 cooled. They did not find that therapeutic hypothermia reduced neonatal mortality. But when we look at the pH, COT pH, only 14% had a COT pH of less than 7. So vast majority of these infants would not have met the cooling criteria for high-income country cooling trials. And only 17% were ventilated, and majority were ventilated for less than a day. So these are very much sicker, less sicker infants in compared to the HELIX trial or the high-income country cooling trials. In HELIX, a vast majority were ventilated, and almost all of them were on inotropic support and so on. But despite this, 17% either died or went on DAMA in this registry data. So this is again, how generalizable is the HELIX trial data? You need to go, we need to look at this pyramid again. Of course, there are settings and populations in India where cooling would be effective, but that is pretty low at the top blue end. And the vast majority, unfortunately, that's not the case. Now, and of course, in pediatric and adult cardiac arrest trials, initially the original trials 10 years back showed that cooling was effective in that population. Hypothermia was neuroprotective and the standard care was hypothermia. But the recent larger randomized controlled trial showed if we give targeted temperature management or targeted normothermia, it is as effective as hypothermia. So many hospitals are now using therapeutic normothermia instead of therapeutic hypothermia following pediatric and adult cardiac arrest. And of course, you can make any guideline as you like, but any guideline is as good as the evidence you have for that. So is cooling still effective in South Asia? I think that's the wrong question to ask. What we should be now focusing on, why is cooling not effective in these settings? So there are two ways to look at that. One is by using MR biomarkers, and other is looking at some mechanistic work. So I'm just going to briefly discuss this before I conclude. So this is a multi-center study we did called MARBLE study to develop good biomarkers of MR biomarkers of later outcome in neonatal encephalopathy. So we developed specific sequences for this to quantify MR spectroscopy metabolites and to harmonize the fractional anisotropy acquisitions. And what we found was that this metabolite called NAA or N-acetyl aspartate. So this is something that is seen only in the neurons in your brain. And when neurons get damaged, the level of NAA goes down. And that predicts your adverse outcome quite accurately. And so does the ratio of lactate to NAA. But the issue with lactate to NAA is that the spread is much more clumped. We can see the nice spread of NAA. You don't see that with lactate NAA. But you do need to do a lot of harmonization work before you do these kind of studies. It's very easy. All the modern scanners come with these packages. So it's very easy to click a button and get the data, but that data will not be accurate unless you do a lot of optimization and harmonization work. So this is what we did. Our physicists went around. We did a lot of work with phantoms, adult volunteers at all the sites in India, Sri Lanka, and Bangladesh. I will not go into details, but there is a lot of technical things you need to do before you acquire the data and before you analyze the data. And particularly because if you do this in 100 cases, you'll get good quality data in only 50. So how are you going to decide which 50 you're going to include and which 50 you're going to exclude? And that'll make a big bias unless you decide beforehand how you're going to exclude poor quality data. So before you even analyze this data, you should have criteria on exclusion, how we are going to do that. And of course, they should be all masked to all the allocation and outcomes and so on. So we had criteria based on the peak line width and a lot of other characters of spectroscopy and diffusion MRI and so on. And then 2 MR physicists independently performed all the analysis using very validated pipelines. And again, this is the flow chart that's again reported in the Lancet paper. There's a very strict protocol of how you analyze this data. Otherwise, you'll have bias. What MRI allows is to look more deeply into the underlying nature of the brain injury and to look at the subgroups more carefully. So when we looked at the conventional MR injury and the MRI scores, many infants had white matter injury. And of course, therapeutic hypothermia was not beneficial, did not decrease the brain injury in any of these infants. When we looked at the MR spectroscopy, no difference between the metabolite levels in thalamic NA or lactate NA. Same with fractional anisotropy, no difference in the cooled or usually care infants. But this also allows us to look at more detail in subgroups. So when we looked at the subgroup of inborn infants, again, no difference. The brain injury was no less whether it was inborn or outborn infants. NA ratios were similar, so was lactate NA and so was fractional anisotropy. Same with moderate to severe HA. There was no effect of hypothermia in that group. Now, so why is this? Is there any genetic differences or is it differences in the mechanisms? So the way you can look at is by looking at, you can look at their DNA to look at this genetic differences. So we did whole genome sequencing in all those infants in the HELIX trial. That data, we're just analyzing that data now. But I'd be surprised if there is any genetic underlying differences. What I think is the mechanisms may be different. So you can look at mechanisms by looking at the expression of genes. So instead of looking at the DNA, you look at RNA. So essentially how things work in your body is that your DNA is telling your RNA, you go and make this protein, and that's how you look at the expression of RNA. So when you have an insult, your expression of RNA changes. So, and this expression of RNA, so you do next generation sequencing, you collect blood in specific RNA stabilizing bottles, and then you do next generation sequencing and you look at each of those genes. So in this graph, what you're seeing is babies with encephalopathy in red and healthy infants in blue. So each of this vertical column is a baby, and each of this tiny line is a gene. And if the gene is upregulated, it's given in red, and if it is downregulated in green. So you can see there's a clear pattern, a difference between HI babies and healthy infants. And the genes which are involved in HI is very different to the healthy infants and also the infants with sepsis and so on. So those genes are very different. And also these gene expressions correlate with the later adverse outcomes. But they also change with time. So gene expression changes with time in babies with HI. So in this graph, what you're seeing is the blue dots are infants with encephalopathy. The darker ones are time points soon after birth, within 6 hours. The lighter ones are later time points. So the lighter piece, so this is done every 6 hours, 24 hours, 48 and 72 hours. So the lightest one is at 72 hours, and in between are 24 and 48 hours. So they separate, but the separation is different to how healthy babies separate. So we can really use this to time the injury when this is happening. And so this is what we did. So we looked at the mechanism. Are there any differences in the mechanisms of brain injury in HELIX trial and in the UK, in high-income countries? So in high-income countries, what we see following acute hypoxia is that the HIF pathway, the hypoxia-induced factor pathway, is changed. So typically NADH pathway, EAF2 signaling, and so on. But what we found in LMICs was a different pathway. It's a new mechanism called ferroptosis, which is prominent. And this is a new mechanism that's been described only recently, only a few years back, similar to, just like we have apoptosis, another mechanism, ferroptosis is another mechanism. which is more related to chronic inflammation and so on. But we also found was that there was some HIF signaling abnormalities in the Helix babies as well, but the direction of that signal was different. So in the UK population, we found that these were downregulated. So you're seeing in this graph, you got the fold change on your y-axis. So if the fold change is less than 0, is downregulated, or it's in green, it is downregulated. If it is in red, it is upregulated. So these genes were downregulated in high-income countries, but upregulated at birth in the Helix trial. So then we tried to look at the trajectory, what is happening. So what we think is happening, and then these are plots that I mentioned from time 0, time T1 is 24 hours, T2 is 48, and T3 is 72. So we have a nice trajectory there. But so the HIF pathway is downregulated at birth in high-income countries, and then it gets upregulated before coming down again. But these pathways were already upregulated at birth in LMICs. So this indicates two things. One is that your mechanism is different, more ferroptosis, more chronic inflammation, and so on. B, the timing is also different. It's probably happening around 24 hours prior to the birth in this population. Now, why is that? What does it? What do we do with this information? Now, you know, these are not things we've been thinking about previously. Is there an effect of ethnicity? Not ethnicity, the socioeconomic factors. How does brain injury, how does these things influence brain injury? So this is a recent data published from the NPU in Oxford, the National Perinatal Epidemiology Unit, by Jenny Kurinsek, you know, highlighting higher risk of death in Indian and BAME population in the UK. So even the deprivation in the UK is having effect on neonatal mortality. We don't know how it's affecting the brain injury. There's some data from Sweden. The immigrant population is having higher risk of encephalopathy. Now, Jenny Kurinsek is a person who did the original trial in Australia. You might remember this trial published in BMJ many, many years back, showing antenatal risk factors were the main reason for encephalopathy in Australia. At that time, the study was very controversial, but this is the data the same team has published recently. So I think we are just learning all these things. There's a long way to go, you know, how these socioeconomic factors are influencing brain injury and therapies. But this is the beginning of that journey. But in a nutshell, these data do suggest hypothermia does not reduce the composite outcome of death and disability in South Asia. And like I said, the underlying mechanisms is different to high-income countries, which might explain the lack of neuroprotection. And we need to study this much more. And I often stop with this slide because I know I'm working with very, very passionate people who always want to do good things. Thank you.